Hello and welcome. In this video, we'll be talking about utilizing a test to identify the situation where trigger points won't release when they're just not letting go to conventional means. This is a situation I call muscle lockdown. And just so you know, I came up with this term many years prior to the pandemic, so I'm not trying to be sensational. This is something that I've given much thought to over the years, as clinically trigger points are super important. Just so you know, Rodin's sculpture here was originally part of a larger composition called the Gates of Hell, which is appropriate if you're a patient with a trigger point that won't release, or the provider unable to make it release. It can feel pretty hellish. So when I first started practice, I really only had two tools in my bag that I felt any confidence in using on real patients. Adjusting and trigger point work. I was a pretty decent adjuster for a new grad. I was even able to help out this giant on the left here. And I spent a lot of time tracking down trigger points, which my thumbs still hate me for. And to this day, although I now believe trigger points are often the proverbial tip of the iceberg, a symptom of a larger dysfunction, I still think they're super important clinically. I've had these trigger point charts hanging in my office since day one. For my money, these are the best. I actually bought an updated set or two, but went back to this old set. They just contain a ton of information. I mean, they're a great patient education tool. I mean, heck, let's be honest, they're a great doctor education tool. You know, it's funny, if I leave a patient in a treatment room for any length of time and I come back in the room, inevitably they're standing in front of my wall here looking at the charts, and I always joke, have you found your pain? So for instance, you can differentially diagnose, sources of headaches from suboccipitals, SCM, TRAP. You can track down the number of muscles that refer pain to the anterior shoulder. I think just recently I realized that you can have trigger points in the paraspinals that up as high as T10 that refer down over to the sit bone. Just a ton of information. So early on in my dealings with trigger points, I noticed a phenomenon where sometimes trigger points would seem not to let go. They just would not respond to conventional treatment. I utilized just a basic compressive treatment, and normally the trigger point should let go within about 15 or 30 seconds. And when they don't let go, I labeled this lockdown, and I spent a lot of time trying to figure out why the muscle wasn't letting go. The reason for this is lockdown trigger points tend not to respond to any form of soft tissue release, including compression or massage or even dry needling. And in some cases, they actually respond by getting worse. I think this phenomenon is responsible for a situation where sometimes a patient will tell you that it felt worse after a massage, an otherwise good massage. And I'm quick to tell them it's not the massage therapist's fault, it's just the muscle is not in a state where it is willing to let go. So to identify trigger points that are in lockdown, I came up with what I call a 6 out of 10 test, which is basically just taking a standard kind of massage compressive technique and turning it into a formal test. So the test is basically you identify your trigger point. In this case, looks like a TFL or glute trigger point. Compress it until you reach a 6 out of 10 on the pain scale. And I tell the patient a 6 means you can handle this pressure, but you wouldn't want me to go much deeper. You hold at that level without letting off. So don't let off when they tell you it's a 6, but maintain that pressure. And ask the patient to tell you if the pain reduces by half. So a successful session would be the pain reduces by half within about 15 or 30 seconds. If the pain won't reduce, you may try repositioning. You might just not be exactly on the right spot. But if it still won't reduce, the muscle has failed the 6 out of 10 test and is considered to be in lockdown. The most common reason for muscle lockdown is that the muscle in question containing the trigger point that won't let go is attached to a joint that is still subluxated. So for instance, if the scalenes are in lockdown and won't release to your trigger point efforts, likely the first or second rib or perhaps T1 or T2 are still subluxated. Or if QL is in lockdown and won't release, perhaps the 12th rib or T12 is still subluxated. Or the rhomboids secondary to mid-thoracic subluxation. So if this is the case, it's pretty simple. If you find the right joint to adjust and are successful, the muscles should then let go. The other most common reason why a muscle would be in lockdown Similar to the first in that it involves a subluxation, but there's an added level of complexity in that the muscle is downstream from another muscle that's in lockdown. So for instance, the elbow extensors might be in lockdown not due to a local elbow joint subluxation, but because the scalenes are still in lockdown via that first or second rib. Another example would be the soleus is not releasing, but it relates to a piriformis lockdown, perhaps a SI joint subluxation. Or the gluteals might be in lockdown, but it's because QL is still in lockdown due to that T12 or 12th rib subluxation. The first two scenarios can be truly a nerve phenomenon, so the scalenes sit on the brachial plexus and the piriformis sits on the sciatic nerve, obviously. But this can happen independently of that situation, just muscle to muscle. So for instance, QL to glutes. There are a couple of other scenarios that a muscle could be in lockdown for other reasons. One situation would be if the patient is pretty acute, if they're just throwing their back out and they've been applying heat to their back for the past couple of days. Let's say it's QL and you got the correct adjustment, but QL just won't release. It might just need a day or two to respond. So if that's the case, it should release by the next treatment. I wouldn't be too quick to write off a muscle in lockdown due to it just being acute. More often the case is that if you get the right adjustment, it will release that treatment, but occasionally it'll take a second treatment. Obviously dehydration could keep a muscle from letting go. Again, it's a pretty simple fix, so I wouldn't be writing off too many situations for this case. And also potentially nutritional electrolyte imbalance or magnesium deficiency. Though in this case, I would say the muscle maybe is slower to respond, but usually does reduce by half. It's not that it won't fully reduce, it's just slower than it seems to be appropriate. So here's a list of muscles prone to lockdown, not an exhaustive list, but the ones that I found clinically most often showing up, the ones that I feel like I'm dealing with most often. This includes both the direct scenarios such as QL and the rhomboids that we discussed where the muscle is directly attached to a subluxated bone or joint, and also the indirect version, so for instance the soleus or the infraspinatus where the muscle is downstream of another muscle that's in lockdown. So there's frequently a correlation between the two concepts of muscle lockdown and muscle inhibition. You can use one to identify or inform or help treat the other. So in our QL example, you may have identified a thoracolumbar subluxation via psoas inhibition. Let's say you've adjusted T11, T12, and psoas is now testing stronger. One final confirmatory step would be to next perform the 6 out of 10 test on that ipsilateral QL and make sure that it's successfully releasing. If you have released all of the relevant subluxations in that region, it should reduce within 15 or 30 seconds. If not, that's your indicator that you still have a subluxation remaining in that region. In this case, perhaps maybe the 12th rib. You've adjusted T11 and 12, but maybe you need to go back and hit that rib separately. This can become super important if you don't get QL, in this case, to the point where it is releasing not only any symptoms related to it, but also its potential downstream effects won't necessarily resolve. So for instance, the gluteal pain or leg pain that's coming from glutes secondary to the QL lockdown. This can truly be make or break in many situations, to getting people better or not. Let's look at another example of how muscle inhibition and muscle lockdown can help really flesh out the clinical picture. So looking at our patient with the tennis elbow from earlier that's secondary to scalene dysfunction. Let's say you treat the scalenes T1, T2, you get the scalenes to the point where they're releasing, their elbow starts to feel better, but they come back and say, hey, every time I get out on the kayak or the paddleboard, my symptoms come right back. Well, it could be because you have lat or lower trap inhibition coming from the lower T-spine. And so every time they're out there paddling, the shoulder is riding superiorly and tightening up the scalenes again and initiating the whole cycle. So until you address that lat and lower trap inhibition, you're not really going to get to the root of the problem, and this is just going to continue to perpetuate. So the question becomes what to do when you find a muscle in lockdown, a muscle that's not releasing. Well, the simple answer is find the subluxation. And in some cases, it is this simple. In your direct cases especially, you just need to find the nearby joint dysfunction, get that to release, and look for your muscle to release. But in other cases, it gets a little more complicated. It could be one of our indirect cases where you're dealing with a downstream effect and the dysfunction is more proximal. Or, as in the previous tennis elbow case, there's just more going on clinically, which you really need to flesh out if you really want to fix the problem. This is where our protocols come in. We've taken a lot of the guesswork out of solving these equations for you, and anytime you encounter one of these clinically relevant muscles in lockdown, we provide a checklist of things to evaluate to ensure you haven't missed anything and that you will be able to get the muscle to let go. So we'll give you a specific example. This is an excerpt from our largest protocol, and you sequentially are doing muscle testing to identify muscle inhibition. Earlier in this protocol, above this region, which you can't see, is you will have addressed any spinal or pelvic dysfunction. And so you're now coming down to the point where you want to test the hip abductors, and you know that if the hip abductors are inhibited, testing weak, it must be coming from the ankle. And the reason you know this is because you've already dealt with any spinal or pelvic dysfunction. So you find the abductors are inhibited. You know that means ankle. So your first step is looking at the mobility of the ankle, doing some I-stim and pin and stretch techniques to get the soft tissues moving better. You then adjust the ankle, and at that stage, if you're successful, you should see the abductors now testing strong. And one final check is to make sure that you've got everything, is you now do your 6 out of 10 test on some of the muscles that are likely have been compensating for the glute medius inhibition. So, for instance, TFL and glute minimus. So you do your 6 out of 10 test, and if they're locked down, we provide a checklist. So if these muscles will not release, your likely suspects would be T10 and 12 in their ribs. You might need to recheck the ankle and make sure you got everything. You might need to recheck the lower back, which ideally you will have already dealt with, but potentially something slipped through, or even the FA joint. And you may wonder, how do we come up with these checklists? As big as I am on evidence, this honestly is more of a case of just sweat equity over the years, working with hundreds and hundreds of folks and seeing what works and what doesn't work and where things went wrong and where people didn't get better. And over the years, we came up with this checklist, and these are all the possibilities of why the muscle would not let go. As you go through our protocols, you'll see that we check for lockdown frequently, usually at least once per region. This helps to ensure that every clinically relevant muscle in that region is able to release. It's in a state where it's willing to let go. It's not locked down. This includes both the direct Travell style referred pain and also the downstream effects that we mentioned. And when you encounter a lockdown muscle, you'll be provided with a checklist of subluxations to evaluate potentially things that you've missed. And if the muscle is letting go, it's not in lockdown, that helps to ensure that you've addressed every subluxation in that region. Just one final check. And this then sets the stage for the muscle to be responsive to things that you, the provider, want to do, if you want to do active release or dry needling, and also the things that the patient would like to do, like foam rolling, for instance. It helps to ensure that it's now going to be responsive to these techniques. Hey, as always, thanks for watching. If you haven't already, check out the case study video, Recurring Calf Strains, to see how I utilize the 6 out of 10 test and the concept of lockdown to solve a 10-year-old injury that wasn't going to resolve otherwise. Take care.